Thank you, Napon. Good afternoon. My name is Andrew. I am a general practitioner and the founder of a clinic called the Red Clinic. The Red Clinic is a private primary care practice in Malaysia. We began with a single clinic and we now currently operate two, integrating sexual health, HIV care, chronic disease management into routine general practice. So I'm beginning this talk by being explicit about it being a private setting because I think it makes an important point that there are patients who choose this model of care and pay for it because they value continuity, integration, and dignity. So today, I want to talk to you about how HIV and sexual health fit into modern primary care, not as an add-on, but not also as just a referral endpoint, but as a part of everyday clinical work. So I will start with a content slide. We will start with a brief definition and maybe some background to the context of my talk. And we'll present some evidence that backs up my opinions, hopefully. And we will do just two short case discussions, and then we'll end with a call to action. So HIV care has evolved significantly over time. If we look back, we will see that the early HIV era was filled with basically an acute life-threatening illness with limited treatment options. And care was necessarily hospital-based and specialist-based, and much of it occurred as an inpatient. And then we slowly progressed into the ART expansion era, where effective therapy started becoming available. And we then focused on viral suppression and how to get a patient to live longer. And nowadays, HIV is managed as a chronic condition, right? People are aging with HIV. They have the same comorbidities that we manage every day in primary care. They have diabetes, hypertension, mental health conditions. And it is my view that the biggest risk in sexual health and HIV today is fragmentation, actually, not lack of treatment. We already have the treatment options, but especially in the Southeast Asian region, I think we are not getting the retention numbers that we would really like. And I would like to argue that this is part of our challenge. So what does integration really mean? To me, it means that HIV and sexual health are no longer add-ons, right? General practices, primary care clinics, shouldn't view HIV and sexual health as an area of interest, so to speak, right? They should be delivered as just routine primary care by the same team in the same place across the patient's entire lifetime. So that begs the question, integrated primary care, is it better than specialized settings? And I can see many ID physicians sitting in the room raising their eyebrows already. But to be clear, I think integrated primary care works not because it replaces the specialists, but it's because it preserves the continuity for the patient and it keeps care connected. So there are some key differences that I think we need to understand about integrated primary care and specialist settings, right? Integrated primary care offers a comprehensive approach by addressing both sexual health and HIV within the context of overall health, ensuring holistic management of patients. It is patient-centric and not department-centric or condition-centric, right? Whereas in a specialist setting, a specialist would primarily focus on a specific condition. So if you had HIV, you would go to an infectious disease clinic, right? But that often limits care to patients with existing diagnoses, referral-based patients, and it may overlook preventive health, it may overlook broader health concerns. In Malaysia now, we live in a country where infectious disease units are thinking that they need their own mental health units, and But at the same time, infectious disease clinics are also the ones discharging stable patients to primary care clinics to continue their care. So we are a little bit all over the place, I think, in Malaysia right now, but that just serves to illustrate my point. So no talk at the HIV Symposium will be complete without reviewing at least some evidence, but this is a touchy-feely talk, so you're not going to see much bar charts or graphs. So one of the most comprehensive systematic reviews that has been performed by Caroline Balstra et al., and interestingly involving the UN AIDS expert group on integration. It suggests that global evidence is there that integration of HIV services with other health services tends to improve HIV testing uptake, ART initiation, retention in care, and viral suppression compared with non-integrated care. And the Red Clinic, coming from a private background where funding is out of pocket, it's interesting to note that there are consistent benefits across all settings and income levels, right, regardless of how much the patient is able to pay and where the funding comes from to deliver the care. So specifically, when it comes to the benefits of primary care itself, right, integration can happen in many different settings, and one very easy example is community-based clinics, and also another one is sexual and reproductive health clinics. But from my lens in primary care, the benefits really fall into three main pockets. The first is retention. We had an opportunity to audit ourselves recently, and we found that actually very good retention numbers for PLHIV being retained in care, and so it's consistent, even in our practice. Yeah, so retention is one of them. Stigma: patients will generally report significantly lower perceived stigma when receiving care in a primary care setting. And I think the reason for that is just because they are mixed into the waiting room with anyone else, right? So you cannot really tell who is a person living with HIV or who is having a cough and cold, in your waiting room. And sometimes even the person registering you has no idea why you are there. And also, cost is also another pocket of benefits. We find that integration reduces indirect costs for patients. So if you went to a hospital for your care, you might have appointments with 3 different departments, and those 3 different departments cannot give you an appointment on the same day. So you end up traveling to the hospital 3 different times, right? So you lose travel time, travel costs, lost wages in some cases, especially in underserved communities, and in primary care, by attempting to be a one-stop shop, you actually cut down on many of those patient out-of-pocket expenditure. So this is a case discussion that's meant to stimulate some thought, hopefully. So I will present 2 cases, and there will be 1 poll in each case. It's a very short case. So the first case is a case about screening after bereavement. So I'd like you to think about your own practice or your own facility as we go through this case. So we have a 54-year-old woman with type 2 diabetes, hypertension, and dyslipidemia, and she attends your clinic for the first time following the recent death of her husband. She was asymptomatic at the time of presentation. So there will be a poll page after this. So I'll give you a little bit of time to read this. In your current practice, would this patient likely be routinely offered an HIV test? So I'll give you a little bit of time to take out your phones, because when I hit the vote button, you're only going to have a couple of seconds to scan the QR code to vote. Keep in mind that this is a woman who has just lost her husband. All right, here we go. Okay, so we have the most answers for B. So it's possible, depending on the clinician. And there are very few for routinely, and the rest are for unlikely and no. Okay, so as you went through that question in your head, I think it might have crossed on your minds how you are going to bring up the HIV test when the person is just asking for a health screening. And that would be a very common situation that we see in primary care, right? Because sometimes when something happens to a family member or a health challenge happens to a relative, people examine their own health and want to come in for a health check. So I will show you literally what we do. This is literally the design that our clinic uses. So we have this in our waiting rooms. So if somebody is in our waiting room asking for a health check, they actually get handed a file that has this graphic on it, right? And we also have it as a tool on our table or on our laptops to go through the patient with the patient, right? So if anybody asks for a health check, so there are 3 columns, right? So they are represented by those smileys or frownies, depending on which one. So I feel fine, I just need a checkup, or I'm worried about energy or lifestyle-related health, and I'm worried about sexually transmitted infections. So we ask the patient to place themselves into one of the baskets, right, on their own, right? And usually this stimulates a question. For example, in this particular patient, which is a real patient that I've experienced, right? So she looked at the I'm worried about sexually transmitted infections and said, can you explain this to me a little bit more, right? So basically the one on the left, I feel fine, that's basically kind of the most basic health screen that we will do. Just safety bloods, kidney function, liver function, cholesterol, full blood count, urinalysis. And the one in between, we would include HbA1c, thyroid function, and stuff like that. And the one on the right has 2 levels, health screening 1 and health screening 2. And the reason is because the health screening 2 includes a nucleic acid amplification test for chlamydia and gonorrhea and mycoplasma genitalium and the like. And that costs a lot more money than if we excluded it. Right, so we give them an option to either include or exclude the nucleic acid amplification test. So specifically with this patient, after she saw that, she started discussing something with me, and she said her husband and her had been sexually active prior to his death. Her husband had been unwell for quite some time, and he had experienced repeated lung infections before he passed away. And she had never previously been tested for HIV or any sexually transmitted infection. She also described feeling slightly unsettled about the circumstances surrounding his death, noting that some of her husband's relatives had behaved in ways that made her feel that there was information being withheld from her. So eventually, she agreed on a set of bloods that involved HIV, and we tested her HIV reactive, and confirmatory test came back positive. So she was then started on antiretroviral therapy and eventually became stable on treatment, and she's now on ongoing follow-up. And the diagnosis was many years ago, and she's still with us now, retained in care, and she now remains well and asymptomatic. A few visits later, she asked me this very specific question, which in hindsight is a lot to reflect on. So she asked me, do I need to go back to the specialist who was treating my diabetes? So in hindsight, as I reflect on this, the question really wasn't really about competence, I think. I don't think she suspected that I was better at diabetes than the specialist. I think the question was mostly about continuity. And at this stage, when the patient asked this question, the patient will have a lot going through their minds. For example, does more than one healthcare facility need to know that I'm a person living with HIV? How can I contain that information? Right? Do I need to tell my endocrinologist that I have HIV? Do I have drug interactions to worry about? All that will be going through their minds, and this question is generated by those thoughts, right? This patient in particular didn't even tell any of her family members, any of her children for many years, and eventually she did. And this patient didn't end up going back to the specialist. Thankfully, the diabetes was not that difficult to manage. So we'll move on to a second case to examine our thoughts and hopefully stimulate some change in the way we think. So this is about an acute febrile illness in a young adult, case 2. So this happens in maybe any doctor who might see an acute presentation of a fever. It doesn't matter whether you're in an emergency department, an urgent care, or primary care clinic. So a 28-year-old male presents with acute symptoms, including a high fever exceeding 39 degrees and generalized body aches. And he has a faint rash on his trunk. And I don't know about everyone else, especially you guys in Thailand, but in Malaysia, the first thing we do is to take out a dengue NS1 rapid test. That's what we normally do, and this patient tests negative. So what do you think would be your immediate next step? So I'll again give you a few seconds to prepare your phones. What is your immediate next step in this primary care setting? Be honest. To some degree, I think we are preaching to the choir here, right? I think we need to get this information outside this room. Okay, most voted for a focused sexual history. Number 2, symptomatic treatment. And number 3, start antibiotics. Very few would refer to a hospital. Okay, so stepping away from this case for a little bit, I want to highlight kind of like a broader concept that I like to bring up, to doctors who are not that familiar with HIV and sexual health. When we talk about STIs, we often talk about certain syndromes, right? We talk about urethritis, we talk about anorectal syndrome, we talk about cervicitis, we talk about maybe genital ulcers, they fit into certain pockets, right? But sometimes I encourage people in primary care or maybe like even emergency settings to think of the simplest things that the patient can present with and see whether you think of a sexual health issue. So can a sore throat be pharyngeal gonorrhea, right? Can abdominal pain be pregnancy or pelvic inflammatory disease and not just appendicitis? Can dysuria be chlamydia or gonorrhea without, discharge maybe? Can a rash be syphilis? And in this case, could fever really be HIV seroconversion? And in doing research for this talk, I actually came across something that I've never noticed before. In the Australian STI management guidelines for use in primary care, and under their syndromes, they have something that I've never noticed. It says sex-associated diarrhea. So that is a very common primary care presentation, isn't it? Right? So if a patient comes with diarrhea, if you were sensitized, it would cross your mind whether this is sex-associated diarrhea. So a pattern that we often get to see, as we diagnose more HIV cases in primary care, is when we diagnose, we ask them for their past medical history, and you often get a story like this, a few months ago, I presented to a clinic, and I had a fever, and the doctor said he thought it was dengue, but somehow most of the dengue tests came out negative, and my platelets were low, but, eventually I was discharged well. That happens a lot. I've heard this story many, many times from a patient, right? Or we hear a story like, if you actually ask the patient, they'll say, actually a couple of months ago, I was diagnosed with shingles, right? Young, otherwise healthy adult, the shingles resolves with treatment, no further workup. I want to make a point that with the benefit of hindsight, if we keep seeing this in, pattern in hindsight, I'm trying to bring the timeline to a different point, and when the patient presents, we should be thinking about something like that instead of missing it. So, going back to the case, right? So I ended up asking him about his sexual history. So he told us that he was on event-driven PrEP, but he admitted immediately that his adherence was not very good. 3 weeks ago, he had a sexual encounter, and he took 2 pills of TDF-FTC 1 hour before the encounter, which by our current, in our current knowledge, we perceive to be a little too late. And he cannot remember whether he took any of the subsequent pills of the TDF-FTC. So eventually, his HIV rapid test was positive, and then I proceeded to confirm the diagnosis again. So he's a PL-HIV today, and eventually, he's now stable on treatment, and his viral load is undetectable. And then similarly, at a later visit, he asked me, do I need to go somewhere else for my HIV treatment? Again, I don't think this question is really a question on competence. I don't think he suspects that I might be better than an ID physician at treating HIV, but I think he had similar thoughts, and he's wondering whether he can get all his healthcare at the same spot, basically. So, lastly, I'll keep my talk short and sweet, is the call to action. So I would like everyone to think about whether some of these concepts and reflections are applicable to your own setting as you go back to your practices after this conference. But I would just like to present a few core principles. There are 3 key elements to me for stigma-free primary care. The first one is the atmosphere. What does the front of your practice look like? Does it loudly scream STD clinic? Or is it relatively neutral? All right. A welcoming environment will reduce anxiety. A modern atmosphere will encourage patients to volunteer information. It will allow them to feel safe and respected, and hopefully it fosters better retention in care in the future. Yeah, so as an example, our waiting room is intentionally neutral, right? There's nothing that in our waiting room that says that we treat HIV. Nobody knows why you are there in the clinic, right? We rely entirely on just word of mouth. Right? And the second principle is about intake, or what I call normalization, right? So case number 1 with the screening algorithm is an example of something like that. Normalizing an intake process, right, through friendly, inclusive workflows helps to destigmatize sexual health and HIV care, right? If we present sexual health as part of overall wellness, patients will feel more at ease discussing their concerns, right? And the third pillar here is about how we manage patients as clinicians. This is about what I mentioned about being patient-centric, right? We must be as holistic as possible. It isn't always easy, and we always need specialist help at some point in primary care, but treating the whole person and integrating the HIV and sexual health care with mental health, self-stigma support, and the rest of the comorbidities that every other primary care patient will go through, like, diabetes and hypertension, to me is ideal for the patient, right? I had a mentor much earlier on in my career who says, there is no patient who wants you to send him away. Every patient hopes to solve everything at your premise. All right. So in closing, if integration can work in primary care, especially in a private model of primary care, and if patients are willing to pay out of pocket for it, then this really isn't that much of a luxury model, I think. It's a value model. There's an exchange. The patients value something that they are willing to pay for. At least that's the way we perceive it in the Red Clinic. So integrated care is maybe not just a model of how convenient it is, right? It's also a model of inclusivity and dignity. And with that, I thank you for your attention. Right.
Thank you for your excellent talk, Dr. Andrew. So anybody have a questions for Dr. Andrew? If you have a questions, you can go to the microphone in the aisle. So I may have one question. Do you see any frictions in primary care in public settings versus the private setting that you are in Malaysia? Yeah.
No, I no longer practice in any public health setting. But there are plenty of my Malaysian colleagues here who do, if you would like to ask them any questions in primary care.
Okay. So some medications or vaccines can be prescribed in some of general practitioners in Thailand. So there may be a barrier when patients access care in public settings. But I don't know in Malaysia whether it's different or not.
Can I clarify that you mean that, for example, some vaccines might not be available in the public healthcare system?
You cannot prescribe them if you are just a general practitioners, but some settings such as medical schools, some just like that, you cannot prescribe them. You have to ask for authorities to just, yes, you can prescribe this, and this is my signatures, something just like that.
Right. So my Malaysian colleagues in the room can feel free to correct me if I'm wrong. In Malaysia, our government facilities are divided into the ones managed by the Ministry of Higher Education, so the universities, and then the main part, which is the Ministry of Health. The Ministry of Health manages primary care facilities of their own, and largely, using vaccines as an example, adult vaccination wouldn't be very well covered in the Ministry of Health formulary. So mostly that gets done in private practice or in a university hospital setting. Yeah.
Thank you, Dr. Andrew. Oh, we have one question.
Just not a question, but just to help answering the question that Dr. Napon asked. My name is Dr. Sairat Noknoy. I am a family physician, vice president of the Royal College of Family Physicians of Thailand. When I was hearing from the executive room about the question that you say that in primary care there are no drugs, there are no vaccine. The problem is mainly if there is no, it's mainly about the regulation. It's not about that. That's why there is no capacity. But Malaysia, the government has empowered community primary care practice. In Thailand, we never ever empower primary care practice. And that's why we have the problem of overloaded in hospitals. People don't know what primary care is. There is no funding, no support, no capacity building for primary care. Just to clarify, Division of AIDS and STI is launching Strengthening Primary Care project. In Thailand, I think the leaders in the past misunderstood that it needs to be driven to community-led activities or community-led clinic. That is not feasible in terms of scaling up. That community-led clinic need to be based in primary care, and then community people do the reach work and integrate the work, and then this is what will make it feasible. So we are on the way, and I really appreciate Andrew's talk, and we'll have a lot to talk to him. Thank you.
Thank you, Dr. Sairat. Okay, so